Assalamu alaikum. Welcome back to today's session, and from my side, Ramzan Mubarak to all of you. Today's session is very important as we will discuss a very high yield topic for FCPS and IMM as well as MRCOG Part 2 and Part 3. And the topic is primary amenorrhea with absent uterus. Today I am going to discuss this topic not in the form of a lecture, but we will start it with the help of a case-based scenario, and then we will reach up to the diagnosis followed by management. So let's approach this case systematically and uncover the diagnosis step by step. So as you can see that today I have a case of a 16-year-old newly married girl. She has normal breast but has never menstruated. So get up guys, what is your diagnosis? I would like to have that you should drop your answers in the comment box so that I can get a clue that how much your diagnosis is perfect regarding this case and how much you are confident about this topic as well. So, should I move to the next slide? Okay. So, the case presentation begins with a patient, a 16-year-old female, presents to a gynecology clinic with the chief complaint of primary amenorrhea, meaning she has never had a menstrual period. Her secondary sexual characteristics such as breast development shows Tanner stage 5, mean the breast were fully developed, and pubic hair distribution are normal for her age. Her medical history is otherwise unremarkable, but she reports having occasional bloating and mild lower abdominal cramping at regular monthly intervals without any bleeding. She also mentions experiencing pain and resistance during attempted sexual intercourse due to a shallow vagina, means she was having complaint of dyspareunia. So, on physical examination, the external genitalia appear normal. A speculum or bimanual examination reveals a shallow, blind ending vaginal pouch approximately 2.5 centimeter in depth. So, what is your provisional diagnosis? Can someone get through the diagnosis up till now? No, if someone are not successful, let's not go in a hurry. We are going to do investigation that is going to give you good clue. So hormonal evaluation, that the blood test for follicular stimulating hormone, luteinizing hormone, estrogen and testosterone show levels within the normal female range, indicating normal ovarian function. And the karyotype analysis, that is a chromosomal study, confirms a normal female karyotype of 46XX, which helps to differentiate MRKH from other conditions like AIS, R. Turner syndrome, like. Okay. So ultrasound pelvis shows the absent uterus and cervix, while ovaries are visualized. And MRI is performed for further detailed evaluation and confirms the agenesis of uterus and the proximal two-thirds of vagina with the presence of normal ovaries. We can also screen such cases for other renal anomalies and skeletal anomalies. So I hope that all of you have the diagnosis I have just mentioned in the investigation as well, that this category falls in a case of MRKH syndrome. And as we all know that MRKH syndrome has got three types, type 1, type 2, type 3, and this case falls under the category of type 1 isolated uterovaginal aplasia because she is having only the normal ovaries, absent uterus and short vagina. So the most important exam point of view or in Viva, you can be asked that what are the differential diagnoses for the case of primary amenorrhea with absent uterus. So it is MRKH, the top of the list should be MRKH, and the second top of the list should be congenital androgen insensitivity syndrome. So as you can see in the table, it is very beautifully made and showing the comparison between the two important conditions. First of all, the karyotype in case of MRKH is 46XX. And in case of AIS, it is 46XY. This is the visible difference and this is going to give you a big clue toward your diagnosis. Gonads are normal ovaries and testes in case of AIS. Uterus is absent in both conditions. Vagina is a form of a short blind ending pouch in both the cases. Breast development is normal in case of MRKH, but it is well developed in case of AIS. Now, the another important clue about the both condition is presence or absence of pubic or axillary hair. Whereas in case of MRKH, these are normal, but in case of AIS, they are sparse or absent. Please note this point. This is very important key point for your diagnosis. And to talk about the testosterone level, they are normal female range, and in AIS they are sometimes normal and sometimes they are in increased level. Okay, so this slide is very important for you all. Now I have brought this very beautiful picture for the better memory, better retention of the difference between the two, that is MRKH and the AIS. You can remember M for Murarian agenesis, R is going to give you the clue about 46XX, and K is for the kitchen ovaries. I would like to add the word kind ovaries instead of kitchen ovaries. So because I like the word kind for K. And H stands for hair normal in case of MRKH. So think MRKH 46XX and the normal pubic hair. Okay, so if you're given the scenario of 46XX normal pubic hair, so you should think of MRKH. And in case of AIS, you can say that A is androgen insensitivity, I is giving you clue about karyotype of 46XY, and S is sparsity. So you should think of AIS when it comes of karyotype 46XY, sparse pubic hair, and the genotype is of male, that is 46XY. So this is going to give you better retention and mnemonic type. So now the examiner trap for you could be that examiner can ask from you in the Viva or OSCE that why are breasts normal in case of AIS. So you should answer confidently that because the gonads in case of AIS are testes, so they are producing testosterone, and this testosterone is then converted into estrogen with the help of a process called aromatization. So this process of aromatization leads to normal breast development formation in AIS. Now comes the very important point of management. You can be asked that once you have diagnosed the patient as a case of MRKH, then how you are going to manage this case. So the management plan for this patient involves a multidisciplinary approach with physical, psychological, and emotional support. Because this could be a breaking bad news for the patient and the family members as well. So you should take this topic, this diagnosis in a very sensitive manner. So psychological counseling is provided to help her cope with the diagnosis, its implication for sexual function, and future reproductive options. The next very important and exam related question from you, that what is the non-surgical method in case of this vaginal dilatation is presented as the primary treatment option to create a functional vagina. This involves the regular use of dilator to gradually lengthen the vaginal canal. This method has a high success rate, that is round about 90 to 95%, and is generally preferred over surgical options. So if the patient is asking for you for a non-surgical method that can lead to good consummation, or that can lead to resolving the problem of dyspareunia, then you can answer that the first line treatment is vaginal dilatation or the frank method of vaginal dilatation. Okay, so the surgical option, if patient preferred that I want to go with the surgical option, or if the dilatation process is unsuccessful, then you can give the option of surgery to the patient, and the surgeries can be in the form of McIndoe, Vicietti, Davidoff procedures. And last but not the least, the fertility options are discussed as well. Since her ovaries are functional, the patient can have biological children through in vitro fertilization using her own eggs and a gestational surrogate. Because she's not having a uterus, so she would need a uterus to implant her embryo formation after having IVF. So uterine transplantation is also a potential, though it is highly complex, but a future option could be. So this was all about a typical classic presentation of a case of absent primary amenorrhea with absent uterus. So please go through the key points and revise this because this is high yield exam question. And I would like to advise you that always approach such cases systematically with the help of history, examination, karyotype, with help of imaging as well. So think clinically and diagnose confidently. And most important, treat the patient, not just the condition. So again, I would like to say that drop your answer in the comments and let me know which topic you want next. And at the end, thank you for watching. And please do like, share, and subscribe my channel. And I am going to meet you in the next topic. Till then, Allah Hafiz and bye. Assalamu alaikum.